So we're going to be talking about healing nerves with regenerative medicine. And I got into this topic for about a year ago. It's a very brand new topic. It's something that I think it's very exciting, and it's something that I think is going to change the way we're treating neuropathies and nerve injuries. And it's something that really gives our patients an option, where before, people with neuropathy or nerve damage didn't really have a lot of options. So let me make sure I figure this out. There we go. I do not have any relevant relationships, financial relationships to disclose. So, Bobby, can I get the screen to go on right here? Thank you. We're going to be talking about a couple of things. Then we're going to just start off with some nerve anatomy, function, discuss some pathologies, talk about evaluating the nerves, healing of the nerves, and then using things like platelet rich plasma and different injections and other supporting therapies. And honestly, each one of these objectives could be a lecture on its own. So the first part, I'm just going to really kind of move through very quickly. I'm not going to spend a lot of time on different types of neuropathies and nerve damage issues. We'll just kind of do a quick basic review. So let's look quickly at just the anatomy of a neuron. So very basic, a neuron is a very long cell. It has the cell body. Then it has the axons that attach to the end organ, which could be a muscle or some other organ. And the axons are surrounded by myelin, and the myelin is created by Schwann cells. So the impulse travels from the cell body down to the end organ through the axons. The axons also have a lot of what we call axonoplasmic flow or axon transport, where different nutrients are coming to the axon from the cell body down to the end organ, and the other way, retrograde. End products and metabolites are going back to get recycled. So the nerve trunk has a lot of components to it, and a lot of people don't really think about what is involved in a nerve trunk. So, the axons and the myelinated axons, unmyelinated axons, are surrounded by a lot of other tissue, a lot of soft tissue. You got the perineurium on the outside, which is a very loose layer, allows the nerve to move back and forth, and it should. When the perineurium is scarred down or compressed, then the nerve doesn't move very well, and that's something that we can actually work on with our regenerative medicine to help the nerves heal better. Then you have the epineurium on the inside, and also very important, there's a lot of blood vessels within the nerves and around the nerves, and that's a very important target when we're treating neuropathies, because as we know, a lot of neuropathies like diabetic neuropathies, the blood vessels are affected. Both the arteries don't deliver the nutrients adequately, and the veins do not drain the nerves adequately, and very often that develops the neuropathy. So the nerves have a lot of blood vessels within them and around them, and then you have the nerves surrounded by, or the axons are surrounded by the myelin and the Schwann cells. And there's a lot of cells within this nerve trunk. There's macrophages and Schwann cells always doing some kind of work. So these are, again, things that we can target when we're trying to help people heal nerves, because as you will learn, all those things are affected in neuropathies. So there's a lot of blood vessels around the nerves, as you can see. There's what they call the vasa nervorum, which means vessels to the nervous system. And they're surrounding the nervous system, and they're inside the nerves as well, like I mentioned. And then you have the nervi nervorum, which is actually little tiny nerves that innervate the nerve trunk itself. And those are also targets that we can use, because the nervi nervorum also maintain the health of the nerve. So, when I went to medical school and I went to residency, nerves had two functions, right? The sensory and motor. And then I realized, and I learned over the years, over the last 10 years, that there's a lot more functions from the nerves too. They have a lot of trophic functions, meaning the nerves actually maintain the health of the tissues that they innervate. So, when the nerves are damaged, the tissue that they innervate can actually become unhealthy. It can become more inflamed. And the nervi nervorum, the little tiny nerves around the nerve, actually maintain the health of the nerve trunk. And that's another target that we can use to help heal the nerves. So, what are some of the nerve pathologies? And like I mentioned before, nerve pathologies, we could spend lectures or actually a whole conference on nerve pathologies, so that's not what I'm going to be doing today. I'm just going to give you a little basic overview. So simplistically, We have mechanical stresses on our nerves, like compressions, like carpal tunnel and ulnar neuropathies. There are stretch injuries. People sometimes stretch their elbow too much and they can irritate their nerves. There's repetitive abrasions, let's say like the saphenous nerve gets trapped right in the medial knee and people are walking and walking, it causes medial knee pain. So the repetitive abrasions can cause neuropathy. And then there's trauma like accidents, falls, surgery. We see a lot of people that have nerve damage after surgery. Nutritional deficiencies, very common. You know, we live in the land of excess, yet we see a lot of deficiencies in our patients. So always we're on the lookout for what nutritional deficiencies they may have. Toxic exposures, we know medications, a lot of medications out there cause neuropathies, alcohol, chemotherapy, and environmental toxins like pesticides and other things, or mercury. These are things that are commonly found in our patients and they can contribute to neuropathies. Then you have autoimmune and infectious diseases. And you know, in my patients, unlike the clinical trials that we're going to look at and some of the studies that we see, my patients usually have a little bit of all of them. They have, you know, some mechanical traumas, some nutritional deficiencies, they're drinking, they're smoking. So that makes it more challenging, but also more exciting because we have a lot of targets to help them heal. So compression neuropathies, you know, the most common one that everyone always knows about is the carpal tunnel, right? Where you have a compression of the median nerve. There's multiple factors that are there. There's the extraneural and intraneural factors. So the extraneural factors are what is the nerve going through that can compress it. There's the fibroosseous tunnels like carpal tunnels, fibrotendinous tunnels. You have fascial piercing. And we are osteopaths, so we know about fascia. We can tell our counterparts what fascia is. But when the nerves pierce through fascia, they can get stuck if the fascia is tight or abnormal or scarred down. So that's one of those extra neural factors that can cause neuropathy. Intraneural, the nerve can get swollen, get scarred down. And then we see histologically there's fibrosis inside the nerve, and then there's some collagen proliferation. And when this happens, we see decreased gliding of the nerve. So when the nerve is compressed, scarred down, and inflamed, the gliding of the nerve. You can take an ultrasound and you can look at your wrist and you can look at the median nerve and you can flex it and extend it and you can see how that median nerve glides, or the ulnar nerve. With pathologies like the compression, that gliding is decreased. And as you will see with some of the treatments, you can get immediate improvement of the gliding with some of the treatments that I'll present to you. So there's also the axon transport system. As I mentioned before, the nutrients are transported back and forth through the axon from the cell body. You got these little tiny guys, little vehicles driving nutrients down the axon to the end organs, and vice versa. Things get brought back. And unfortunately, in pathologies, this axon transport system can be inhibited. It can be inhibited from compression or metabolic and toxic factors. So even conditions like diabetes or alcohol or chemotherapy-induced neuropathies, that axon transport system is reduced. And then we very often find that people that have a peripheral metabolic or toxic neuropathy, they are so much more prone to compression neuropathies because their axon transport system is already compromised from the condition that they have, and then the compression, a very light compression like in you and I, may not cause any neuropathies. In these people, would actually cause a neuropathic condition. So, you know, diabetes is one of the most common neuropathic condition that we see and we treat. And, you know, probably all of you guys are seeing patients with diabetic neuropathy. And what's going on with diabetic neuropathy? There's very often an oxidative stress. There's accumulations of oxidants, fructose and sorbitol. They all are toxic to the nerves. There's very significant microvascular disease where we see the capillary is not functioning properly. And the amount of microvascular disease is correlated to how bad the neuropathy is. There's neurogenic inflammation, activation of NF-kappa B, which is a very inflammatory transcription factor, and then macrophages. Macrophages are actually activated to become inflammatory, and this is all happening in the nerves of diabetic patients. They have impaired axon transport. Schwann cells, which are very important to keep the health of the nerve, are dysfunctional. They actually look kind of weird. They don't have the projections that they're supposed to, and they don't produce as much nerve growth factors that keep the health of the nerve. And then the axons and myelin break down. And as we see in diabetic neuropathy and a lot of the other neuropathies, the distribution is what they call the glove and stocking distribution, where you see the pain and numbness and burning and all the other symptoms in their hands and feet. And typically, the symptoms of neuropathy, I usually like to look at them as positive and negative symptoms. Positive is what is added to them, so like the pain, which can be constant. They can have allodynia, which is pain that is, they feel pain with things that shouldn't be painful, or hyperalgesia, a little bit of a painful stimuli they perceive as very painful. Very often they complain of burning, cramping, cold sensation. I have patients that tell me they feel like they have cold water running down in their feet. And then you have the negative symptoms, which are, what are they lacking? So they usually have numbness, weakness, lack of proprioception. That's very often I see people, they have a poor balance, they can't walk very well because they don't really feel their toes on the floor, and their toes are not connected to their leg, to their knee, to their head. And there's that proprioception deficit. And then there's usually some skin trophic changes as well. So, how do we evaluate this? Obviously, we do a physical history, but there's a couple other things we have. One of the things I do nerve studies, EMGs, and nerve conduction studies. So we can do those to evaluate the health of the large fibers. So nerve conduction studies, how many of you guys send patients for nerve conduction studies? Okay, so nerve conduction studies, basically, we do use a little tiny bit of electrical stimulation on the nerve, and then we measure how fast and how strong that impulse travels down the nerve, and then we can tell if the nerve is healthy or not. If it's slow, we know there's some myelin deficits. If it's a low amplitude, we know that there's some axons that are missing. And then we can do the EMG electromyography, where we use a little tiny needle in certain muscles, and that tells us if those muscles are functioning well through those nerves. And it can help us differentiate, are these axonal damage, is this myelin damage, where is the damage, where is the compression, and how bad it is. So usually when I treat patients for neuropathy, they always get an EMG before any of the treatments just to track their progress. The other thing that's more new, kind of up and coming in the last couple years, is using ultrasound for looking at neuropathies. And you can measure the cross-sectional area. And a lot of the studies, well, actually some of the studies that I'm going to mention, but a lot of the studies, if you ever look at neuropathy studies now, are often quoting the cross-sectional area changes in nerves before and after treatments. And that's important because when a nerve swells or the fascicles within the nerve swell, you can see those on the ultrasound. So a normal median nerve size is about 8 to 9 millimeters squared, where a carpal tunnel, you're looking at about 14 to 15 or even more. Same thing with the ulnar, you got about 7 to 8 millimeters squared, and with neuropathy, you see that nerve being swollen. So you can see on this picture right here, there is actually a median nerve that's measured. They measure the cross-sectional area, and it's 14 millimeters squared. So this is a pathological median nerve, and it's done at the distal crease of the wrist. So I did bring my ultrasound today. During breaks or during lunch, if you guys want to, please come and stop by my table, and we'll just scan your nerves. I'll be more than happy to show you how to scan for the ulnar median nerve, and we'll have a good time. I love scanning nerves. I could scan nerves all day, and that's what I do at work. Ultrasound of the ulnar nerve. Here is another one. You can see on your left is a normal ulnar nerve with a cross-sectional area of about 8 millimeters. And then on the right side, you can see a large ulnar nerve at the same place, which has about 29 millimeters, so a lot more swollen. I've injured my ulnar nerve a couple weeks ago. I banged it, and it's swollen. So if you want to see a swollen ulnar nerve, I invite you, come and see mine. You're more than happy. So obviously, there's other things we do when we evaluate patients for neuropathy. We want to go down and ask them about their history, their physical, look at their labs, nutritional evaluation, exposure. What are their diet? What are they eating? What are they eating, and what are they actually absorbing? So a lot of patients are on proton pump inhibitors, and if you guys watched some of my lectures before, who's got patients on proton pump inhibitors? Yeah, all of you guys probably do. Unfortunately, sometimes we need it, and sometimes maybe not. But patients, even though they might be eating a good diet, they're often not absorbing their nutrients. So they can be B vitamin deficient, even if they're eating, red meat or whatever else. Blood sugar panels, always looking at blood sugars because we know blood sugars are toxic, or high blood sugars. Thyroid panels, autoimmune panels, and I also do micronutrient tests. Anybody here does micronutrient testing? So micronutrient testing is a great way to test your patient's nutritional status. And there's a lot of labs out there that are looking at the minerals and vitamin levels in either their red blood cells or white blood cells, which is a lot more accurate than just looking in the plasma. And you get a nice feeling of what the patient is actually absorbing and what kind of nutrients they're having. So we often do that with our neuropathy patients, just because our neuropathy patients, and probably most of your neuropathy patients, have many comorbidities that have to be addressed. So when the nerves get injured, then there's a healing process, right? When a nerve gets cut or compressed, it goes through what is called Wallerian degeneration. So the distal stump actually degenerates. You have some Schwann cells and macrophages that eat up some of the distal axons and things that are not actually needed there, and they create a new environment for the nerve to heal. So again, that's another target, is helping, what can we do to help those Schwann cells and those macrophages actually create that new milieu to help the nerves heal a little bit better. So what happens, the macrophages and Schwann cells actually, like I said, eat up the debris. Then the Schwann cells line up and make these lines of Brugger bands, and those actually guide the axons to go ahead and regrow. And then there's angiogenesis, so new blood vessels are recruited to come to that area. And then macrophages need to change from M1, which is the inflammatory type of macrophage, to M2, which is the one that actually starts the process of regeneration and healing. And if they can't transform from M1 to M2, then the patient has a hard time healing. So that's another target that we can use to help those macrophages help heal. And typically, regeneration of the nerve is about 1 millimeter per day or maybe 1 inch per month. That's when it's unaided and it's still relatively healthy. Sometimes sicker nerves heal slower, and sometimes nerves that we help with regenerative medicine can heal faster than that. So what is needed for a nerve to actually heal? Well, we need to do something about that compression site, which is not necessarily always a surgical decompression. There are certain things we can do with our needles and syringes. There are certain things we can do with therapy and osteopathic manual treatments. We can decompress those fascial restrictions, those ligamentous osteofibrous tunnels. So there's a lot of things we can do to help them remove that compression, improve the movement of that nerve, that gliding, decrease the edema and inflammation, increase blood flow to that nerve. We need to do that to help it regrow. Improve the nutrition delivery. So again, we want that axon transport system to be healthy for the nerve to heal. And stimulate cells like the Schwann cells. Can we do something to help the Schwann cells go in there and start helping the axons and the myelin healing? Stem cells, can we recruit stem cells to that area? Can we get the macrophages to go from M1 to M2? What can we do? So, Schwann cells are very important cells to the nervous system. They're the most abundant nervous system cells. They produce and maintain the myelin, as we know. They release neurotrophic factors. So they release these growth factors that help the axons and myelin actually grow. And actually, during non-regeneration, during just health, those Schwann cells keep on releasing those growth factors to help maintain the health of the nerves as well. So a lot of neuropathies have Schwannopathy or Schwannopathy, you can say, where the Schwann cells are dysfunctional, like in diabetes, and they cannot maintain those healthy axons. So that's another target we can treat. They communicate with the axons and stimulate the growth. They migrate to that area. So if there's an injury to a nerve, the Schwann cells migrate to that area, and then they release all those nerve growth factors or the brain-derived neurotrophic factors, and they orchestrate this whole healing process. So when you have an injury, is there something that we can do to help those Schwann cells to migrate? And that is another target for us to help nerves heal. As I said earlier, they create these corridors for the axons to go through and heal, and they are activated by different growth factors like endothelial growth factors, and we'll see how we can use those growth factors to get these guys to come to the area and do their job. And in neuropathies, as I said, Schwann cells become dysfunctional and they don't do their job. So how can we improve patients' healing process? Because obviously, we all know that our body wants to heal. And as osteopaths, we're told and we learn what can we do to help the body heal a little bit better, right? So what can we do? And what I do, and what's kind of really cool and exciting, it's very new, why use regenerative medicine to help the body heal those nerves? It's not like my regenerative medicine is it. It's the treatment of, and that's the only thing that heals them. No, it's actually what helps the body heal itself. And we as osteopaths, we know that. That's our job, is what can we do to help the body heal itself. So there's a lot of different modalities in regenerative medicine to help nerves heal. I'm going to be talking about platelet rich plasma, but there's other things. There's dextrose, there's stem cells, and there's some, I guess, questionable studies and questionable practices out there on using stem cells. Like, how many of you heard of these chiropractic practices that they inject millions of stem cells from umbilical cords, and they have their nurse practitioners or somebody else who hasn't had much training in this just inject it, and they say, oh, it's going to get there. It's going to get to the area where it needs to. So we got to be really careful about who's doing the regenerative medicine, how it's being done, and what's their training, and what is the evidence behind what they're doing, right? We always want to practice evidence-based medicine. So what is platelet-rich plasma? How many of you use platelet-rich plasma? Or how many of you have heard of platelet-rich plasma being used? Right? So platelet-rich plasma, there's a lot of different products. So basically, we take the patient's blood, we spin it, we concentrate, or we get rid of the red blood cells, and then we concentrate the platelets. And then there's different types of products. There's the pure PRP, which doesn't have any red blood cells and has very minimal white blood cells, so it's mostly platelets. And then you have other types of products where there's more white blood cells, and then there's different concentrations. How much do we need to concentrate the platelets? Do we need it 2 times, 3 times, 5 times, 10 times the baseline? And there's all these different studies that show us, what are the optimal concentrations. So we know for neuropathy, it's usually about 2 to 3 times the concentration, while for an elderly gentleman who's got a rotator cuff tear, we usually need higher concentration, like 5 or 6 times the concentrations of platelets. So when you're doing platelet-rich plasma, you really have to be aware of, what does the evidence show, because you can actually cause the healing to not go as well or actually make it worse. There's other products like plasma-rich growth factors, plasma-rich in fibrin, platelet-poor plasma. So these are all things we can use. So what is it in platelet-rich plasma? So in the platelets, there's these little granules, and when the platelets are activated, they release these growth hormones in their granules. They release these biomolecules that are just these wonderful healing molecules for the body. And the nice thing is they're patient's healing molecules. They're nobody else's. These were made by the patients for the patient. So what do these molecules do? They can be anti-inflammatory. They can improve muscle growth. They actually decrease muscle atrophy. They're very neuroprotective. You have the bone-derived nerve growth factors, like I mentioned earlier. Those are released also by Schwann cells. You have angiogenic growth factors, like vascular endothelial growth factors. You have different growth factors that stimulate axonal growth. So, what does PRP do when we inject it around nerves? And I'll tell you later how we do it around nerves. So these are the things that's been shown. This is the evidence that we have so far on in vitro and in vivo studies on plates and on animals and on humans. We know that they are anti-inflammatory. It's usually a pure PRP. So it's the PRP that doesn't have the white blood cells, tends to be more anti-inflammatory. Once we get the PRP that has a lot of the leukocytes, tends to be a little bit more inflammatory, so we don't use that around nerves. It can be analgesic. I have patients where I've injected PRP, and the next day they're like, wow, and everything feels so much better. And there are some patients that say, no, they're sore, so it can go either way. But PRP can be very analgesic. It stimulates Schwann cells. It stimulates axon and myelin regeneration, stimulates angiogenesis, and it improves muscle regeneration. So PRP reduces and resolves neurogenic inflammation. We know that it reduces the activation of NF-kappa B, which is a pro-inflammatory transcription factor. And when you put a little bit of PRP around tissues that have a lot of NF-kappa B, it decreases that transcription factor. It reduces nitrous oxide and cyclooxygenase, kind of like COX-2 inhibitors. It promotes those macrophages to actually polarize from M1 to M2. So remember I told you earlier, those macrophages They need to do their job first, clean up the debris, and then they need to be polarized to M2, which is their anti-inflammatory and repair kind of stage. So PRP actually does that for these macrophages, and it decreases the edema of the nerve cells. There's a lot of analgesic properties of PRP, and a lot of animal studies showed that when you inject PRP around, let's say, their spinal cord, like in this study, rats that had a spinal cord injury had a neuropathic pain, they had a lot of allodynia and hyperalgesia. A little bit of PRP in the epidural space decreased a lot of that. Same thing with the studies that looked at sciatic nerve lesions in animals. These animals typically have a lot of allodynia and hyperalgesia. You put a little bit of PRP with the right concentration and the right technique, these symptoms significantly decrease. And we know, very importantly, that PRP stimulates Schwann cells. And as I said earlier, Schwann cells are vital to the health of the nerves. They're vital to the regeneration of the nerves. Is it a cut nerve? Is it a compressed nerve? Is it a neuropathic nerve? Schwann cells are extremely important to help that nerve heal and feel healthy. So in this study right here, they plated some Schwann cells on different concentrations of PRP, and they looked at the proliferation of the Schwann cells, the migration, and also the release of the growth factors. And it's interesting, you can see that, oops, can I go back? Let's see, there we go. Yeah, so certain concentrations, the very high concentration of the PRP did not help the Schwann cells survive or proliferate, but the right concentration at the 20 and 10% helped the Schwann cells proliferate, grow very nicely. Same thing with migration. We see on that graph on your right that at the right concentration, those Schwann cells were actually migrating to that area of that right concentration of the PRP. They also looked at what do these Schwann cells do. So we know that after we have the right PRP in that area, that the Schwann cells travel to that area and they proliferate, but do they release the growth factors? And they do. It's been shown that the nerve growth factor and the brain-derived nerve factor all increased when these Schwann cells were kind of hanging out and living in this PRP that was at the right concentration. We know that PRP stimulates angiogenesis, meaning it improves the blood vessels to grow to that area. And as I told you earlier, in diabetic neuropathy and all kinds of neuropathies, there's usually some kind of angiopathy. There's some kind of vascular disease that prevents that nerve from being healthy. So in order to heal that nerve, we need those blood vessels to grow to that area. And it's been shown in multiple studies that PRP can do that. In this nice rat study, they took diabetic mice and induced a severe limb ischemia by removing their iliac, saphenous, and femoral arteries. Ouch. Doesn't sound like fun. I'm sorry about these, these little rats, but it helped us understand. So they remove these arteries, and then they want to see, in 4 weeks, what happens. Do these blood vessels grow back, and how fast do they grow back, and what can we do to stimulate them to grow back? So they found that injecting a little bit of a PRP, actually implanting a little bit of PRP that was slow release, improved those blood vessels to grow to that area, to that limb, pretty significantly. So on the graph on your left, you will see that the PRP group improved their limb perfusion, up to 80% of the control limb. They were comparing it to the non-injured limb. And the injured limb, after 4 weeks, had about 80% of their blood vessels perfusion again. And this was much more compared to the limbs that weren't injected. Let's say the control, which was at 40%. Significant improvement with vascular growth. And you can see this picture of the lower rat. The one is controlled. The left limb this is a laser Doppler perfusion imaging. And you can see that the top picture shows a lower rat with the left limb not perfusing very well. And as you go down to the PRP group, after 4 weeks, their perfusion is pretty much the same as their other leg. So that PRP really stimulated those blood vessels to grow to that area. And I think this is a very exciting area for people that have peripheral vascular disease. So how many of you see patients with peripheral vascular disease? I know Anita is one of them, right? So there are some really interesting studies being done. Dr. David Harshfield is conducting some studies where he's actually injecting PRP around vasculature and of the limbs, and they're watching that these blood vessels are growing and these people's peripheral vascular disease is improving. Very exciting stuff. This is kind of hot off the press. So, is there any other animal studies? So this is a nice animal study that looked at injecting PRP into injured nerves. So in this study, Dr. Michael Sanchez from Spain, who wrote books on PRP, and I've been in contact with him, has amazing wealth of information. They took 16 sheep and they compressed their common ulnar nerve, common fibular nerve. As you can see, it's a pretty brutal thing that happens. They took out the nerve, and then they compressed it, and they caused a axonotmesis, meaning they damaged the axons pretty severely. And then they injected some PRP in it, and then they put some PRP on top of it, a little bit of a clot. And then they followed them. So they had 3 groups: spontaneous healing, saline injection, and then platelet-rich, plasma-rich in growth factors, what they use. And at 12 weeks, they had a sacrifice and a final evaluation of the sheep and kind of looked at them, what happened, right? So here's the kind of timeline, what they're doing. So first they had the surgery day, then 2 weeks they got an injection, either saline or PRP, 4 weeks, another injection, and he's doing intraneural injection. So if you look at the picture on the right, you will see that he's using an ultrasound and he's actually putting the needle inside the nerve, and he's doing an intraneural injection, which there's some pretty interesting studies showing that that is relatively safe if it's done right. Please don't try this at home. I do this with my patients, but it has to be done very accurately. You can inject in the nerve. It's intraneural, but not into the vesicles. You have to be very careful how you do that. But this is what Dr. Sanchez did. And then he measured, he looked at the axons, and he wanted to see what happens. So it was really interesting that after, those 12 weeks, the distal stump showed significant increase in the axon density and in the size of these axons, very close or getting closer and closer to a normal nerve, while the other nerves did not show that. So again, he showed that in this in vivo study, these axons were regenerating much faster and much better. And also the muscles that the axons were innervating, they were actually improving much better. These animals, their muscles looked a lot more like their normal muscles compared to the other studies. So they had large myofibers and good strength in some of these animals. So we know that, I inject into muscles all the time too. PRP intramuscular is very good to help muscle grow. This is a study done by Dr. Hussein. He looked at 104 patients with chronic back pain, and when he did an MRI on their backs, most of these patients, actually all of these patients, had multifidi atrophy. And we see this in our chronic back pain patients when the multifidus is atrophied, and it contributes to their instability, to their weakness. So he just injected intramuscularly some good amount of PRP, and then he followed them. And then, he did 3 PRP injections, and then I believe it was about 1 year later, he repeated the MRI. And a lot of these patients, their muscles regrew, and they also had less back pain. But for this purpose, for our purpose, it actually stimulated muscle regeneration. So when I'm treating neuropathies and there's atrophy of the muscle, we typically treat their end organ. We're treating their distal muscles too, to help them regenerate quicker too. It calls on to the satellite cells, and then the satellite cells stimulate that muscle to regenerate. So when I'm treating neuropathy, I'm always thinking, proximal, spine, the nerve, and then distally. What is the end organ? And you have to treat all of those areas if you want the best results. So Dr. Sanchez did a lot of studies. This is one of his case reports. It was really interesting. He had a patient who's a 28-year-old male soccer player who had a very significant varus stress to his knee, had an ACL and an LCL tear, but a significant stretch to his fibular nerve. And he had a foot drop. His tibialis anterior had 0 out of 5 strength, meaning there was nothing, not even a twitch. And then the extensor hallucis longus had maybe just a twitch. So this patient was seen by Dr. Sanchez 9 months after his injury. And again, he did an EMG. There was no recruitment. I mean, this guy was left to say, well, this is it. You're done. 9 months. You haven't healed. There's nothing we can do for you. You won't be able to run. You're going to have to wear an AFO. So Dr. Sanchez started injecting PRP, and he started the PRP injection 11 months later, so about a year after his injury. And this guy cannot move his foot at all. So he did the intramural injections right at that injury. He did it distally and proximally. And the patient received 7 injections over 9 months. And at 9 months, he was able to walk and run without the AFO. And at 23 months post the injections, his muscle testing was 3 out of 5 on the tibialis. And remember, this is the one that 1 year later had nothing, was 0. And then the EHL was 5 out of 5, okay? This is the one that he could just barely move. Now his extensor hallucis longus, complete strength came back. So, I mean, this is very hot stuff. These are patients that, you know, before we're told, well, there's nothing you can do. Here's an AFO and good luck with the rest of your life. But no, we can help these patients. I have a few of these drop foot patients. Mine may not be as easy as this, his. So this patient is Miss P. She's a 65-year-old female who developed left foot drop in June 2019. I saw her and I did an exam. Very minimal dorsiflexion and EHL movement, almost nothing. And then I did an EMG on her, and a nerve conduction study showed no response on the deep peroneal nerve. The EMG showed significant denervation, very, very minimal, almost no activation. So she actually did 6 months of physical therapy and didn't get much better. She was kind of plateaued, wasn't able to move that foot, had to wear an AFO, and her hip was weak. She actually had an L5 radiculopathy, and this was one of those diabetic neuropathies. So this woman was not the healthiest person to begin with. She had diabetes that wasn't very well controlled, and she developed a diabetic neuropathy, diabetic radiculopathy. She also had diabetic polyneuropathy. So her nerves were just not very healthy. And we see this. Sometimes patients get these radiculopathies without even a significant compression. And you remember, like I told you before, patients that have an underlying neuropathic condition, any little tiny bit of compression can cause them to have severe symptoms and severe outcomes because they have, sick nerves. So this woman had sick nerves, unfortunately, and at 6 months, still nothing was changing. So in December 2019, we started PRP injections. First, I started with some perineural injections. I also was doing some lasers on them. So all my patients get a PRP and laser treatment, and I'll tell you a little bit why. And she was improving significantly. She had 8 injections over 9 months. We started with the perineural, and then when I've been in contact with Dr. Sanchez, I started doing the intraneural injections, and she noticed quite a big difference once we started doing intraneural injections. So I would do an epidural on her, and I would do distal injections as well, and the intramuscular injections, and then she would have a laser treatment. And after 9 months, her dorsiflexion improved, 3 out of 5. Hip abduction is 4 out of 5, so she can walk now, and she doesn't have that Trendelenburg anymore. She walks with a cane with no more AFO. She's still having a lot of blood sugar issues. So if you can go ahead and play this video for me. This is most recent. This is actually a couple weeks ago. So her left foot is the one that was a complete foot drop, and there she's moving it. And then you're going to see I'm going to change the angle, which is going to show a little bit better. And there she is. So she's got nice movement. That EHL is still lagging behind, but she's functional. She can clear that foot, And before, for 6 months, she wasn't getting anywhere. It was complete foot drop, and she was dragging that foot, and she was a fall risk. So these are the things that we see. These are tough patients. These aren't selected one little nerve injury. These are patients that have so many comorbidities, but they can get better. Not everybody. I've had patients where, they had surgery and they had developed a post-surgical L5 radiculopathy, and we've tried about 3 to 4 treatments and nothing changed, and we decided not to do it any farther. Some, unfortunately, you just can't, but there are many that you can, and those are the patients that we want to identify and try to help them, right? Here's another preliminary report from Dr. Carrera, and I've been in contact with Dr. Carrera. He's from Colombia. He did a really cool case report, or actually a case series of 250 patients who had degenerated disc disease and had a lot of back pain and some radicular type symptoms, and he did PRP with an epidural and showed significant improvement, and then he followed them with an MRI. So when I contacted him after the study, he sent me this preliminary report that he did, and he injected patients' brachial plexus and their peripheral nerves, and he had quite a significant amount of patients. And so for people who had brachial plexus post-herpetic neuralgia, out of the 9 patients, 8 of them got better 3 months afterwards. This is just with one treatment. Post-herpetic neuralgia, occipital nerve, intercostal, 12 patients, and most of them are getting better. This is not the best way that he reported it. He's going to give us probably some more graphs when the study becomes available. But very interesting. This is, like I said, very hot and new topic. Patients' nerves can heal with the right treatment. What about diabetic neuropathy, right? How many of you have patients with diabetic neuropathy, right? They're everywhere, and it's miserable. These patients, go home in the evening and their feet are on fire. They can't go to sleep. They're moving. They have restless leg syndrome. So it's a sensory neuropathy, sensory motor neuropathy that results from damage to small fibers. Usually that's the first early sign. And then you get large fiber damage. So they get the stocking glove pattern. They have the loss of sensation, vibration, pinprick, cold, and then they have symptoms such as pain and burning. So there's a very nice study done in Egypt just very recently. This was just published in 2020, so this year, very hot off the press. They did a randomized trial of 60 adults with diabetic neuropathy, divided into two groups, medical treatment and medical and PRP. And the medical treatment received strict glycemic control, some vitamin B complex, alpha-lipoic acid, who uses alpha-lipoic acid under diabetic patients? Yeah, in Europe, it's kind of the standard of care on all the diabetic neuropathy patients. It improves the blood flow to the nerves nicely. And then they put them on pregabalin. So everybody got that, and then half of them got the PRP as well. So they evaluated their VAS score for pain and numbness, and then they did some nerve conduction studies, and then the Toronto Clinical Neuropathy score. Bobby, how much time do I have? Okay. All right. So they did perineural injections, PRP for diabetic neuropathy, right? So they injected about 1.5 mL of PRP around all these different nerves. And this takes a lot of time. You have to have a lot of experience with ultrasound, and you sit there and you're just injecting each and every one of those nerves. So they injected the median, ulnar, radial, superficial, perineal, tibial, sural, and saphenous. So Bobby, if you can play this video for me, please. So this is me injecting actually the saphenous, the superficial perineal nerve. As you can see, it's very slow. If you can see, the needle is going in between the fascial layers right here. And now I'm going to be doing a little hydrodissection with the PRP around the superficial perineal nerve. And that's what it is. You sit there and you look at the leg and you inject every single nerve. It takes a lot of work, but it's very satisfactory because these patients, come back a month later and they're like, wow, I can start feeling my feet. The burning is gone. And then they're like, what else can you treat? Can you treat my back? It's pretty exciting. I'm very satisfied with this work. Ever since I started doing it, I've seen amazing things come out of it. So anyways, back to the study. So they looked at these patients, and 1 month later, they looked at their pain and numbness VAS score. So 1 month later, the PRP group, their pain dropped from 7 to 1. 3 months later, still stayed at 1. 6 months later, still stayed at 1. Right? This is pretty impressive, right? Same thing with their numbness. Their numbness decreased. Now, the control group, which was the medical, they didn't have as much improvement. And then when they did some objective studies, they looked at their nerve conduction studies, their conduction velocity improved in those nerves. Their amplitude improved. These people were getting better. Very exciting stuff. Right? And then the Toronto Clinical Neuropathy score, which looks at pain, numbness, tingling, weakness, apraxia. The score, the higher you're on the score, the worse your neuropathy is. So then they follow them, and you can see that as the months went by, they got better and better and better. Those Schwann cells got activated by the PRP, right? And axons started coming back. The vascular endothelial growth factor stimulated the blood vessels to grow there, and these nerves were now getting better vasculature to it. So very exciting stuff. We also know there's a lot of studies looking at PRP and carpal tunnel, and we know for moderate and mild carpal tunnel, there's level 1 evidence that PRP is very effective. It treats the carpal tunnel very well. There's a couple studies that looked at PRP versus corticosteroids, and most of them show that the PRP gives us better results. Longer lasting results, better improvement on the nerve conduction studies, improvement of the cross-sectional area on that ultrasound that we looked at. All of these studies use just a single injection, and there's other ways to do it. You can do multiple injections, and there's different ways to inject it too that can make it more efficient. And here's another picture from Dr. Sanchez. He uses it in he's a surgeon, so he uses it in his surgical decompression. After he does the decompression, he injects the nerve with PRP and puts some fibrin clot, and he claims that he gets a lot better results. And there are some studies coming out there right now showing that if you add this to surgical decompressions, you get better results. So this takes a lot of work. You really need to know your PRP. To inject a lot of nerves, you need to have a lot of PRP. You can't just use your regular PRP kit and get your 5 mLs of PRP. No, we usually, for a PRP injection, I usually have about 20 mLs of PRP that I need to create. So it's a lot of blood, and you need to know what you're doing. So we are constantly, in our lab, we are constantly checking our PRP. We're testing it. We're refining it. We're trying to, how do we get the max amount of volume with the right concentrations? Because you can screw things up. If you get the wrong concentrations, you can actually inhibit. It can be, if it's too high in a concentration, it can be inhibitory. And we do this in our lab constantly. So, how do we inject the PRP? So there's a superficial treatment, which Dr. Liftoff taught, and I'm not going to go through that. Each one of these could be a lecture of his own. I'm going to focus on the hydrodissection. Hydrodissection, we know that light pressure around the nerve can cause morphological changes in the nerve and can cause neuropathic symptoms. So hydrodissection is using the fluid to dissect, to open up around the nerves. And it releases and frees up the nerve. It relieves the low pressure that's around the nerve. It helps the vasa nervorum to kind of pump the blood in and out. The veins actually take the blood, or the toxins out. Improves lymphatic drainage and relieves the perineural adhesions. So we very often see that the nerves, when we scan them, there's a lot of scar tissue on the nerves. You can break up those scar tissues without having to do it surgically, right? And usually after post-hydrodissection, if you look at the movement of the nerve, it improves like immediately. I do a hydrodissection and then we scan it with the ultrasound and all of a sudden that nerve is moving. So you have the patient go home and they're just gliding that nerve to make sure it keeps on moving. Dr. Dellon, a brilliant plastic surgeon, he figured out that if you release the nerves surgically for patients with diabetic neuropathy, you can get significant improvement. His patients, about 33% of patients that see him with diabetic neuropathy, he fit the criteria. He's got a specific criteria who will be successful and who is not. But out of those 33% of patients, about 80 to 90 get great improvement just by releasing those nerves. He's helping that axonoplasmic flow, and their diabetic and other polyneuropathies are improving. I'm not doing that surgically. I'm doing it with a needle and just a little bit of hydrodissection, but it's the same idea. So when I'm doing these hydrodissection, there are specific places that we know that nerves get constricted. Like we know the tibial nerve at the soleus sling gets constricted. We know the tibial nerve at the medial ankle gets constricted. So these are all targets that we can hydrodissect these nerves and help them improve. Or you can surgically release them as well. So here's a hydrodissection for carpal tunnel. There are some pretty good studies that just doing hydrodissection with saline, nothing else, improves these patients' symptoms. All it is just opening up those nerves. So Bobby, can you play the first video? This is me doing a hydrodissection on a patient a couple weeks ago. So the first video, the median nerve is right in the middle at the center line, and you can see the needle going in, and now it's injecting fluid, and what I'm doing is I'm separating that nerve from any of the scar tissue and that transverse ligament, just kind of opening it up, freeing up any space, or freeing up anything above that nerve. We want to basically release it. There you go, it released just right now. So any adhesion that was there was just released right now at that moment, right? And then, Bobby, if you can play the second video, please. So then, when the top is done, I go underneath, and then we release it from any of the tendons as well. So this one was a little bit more, he was stuck a little bit more here. As you can see, he doesn't want to go. There's a moment that when we go in and finally that adhesion releases. So I'm trying and struggling to make sure I get the needle in the right place, and all of a sudden, it lets go, and it pops up. It's a beautiful feeling. The patient's like, wow, they really notice a huge difference. So this patient couldn't do the PRP for multiple reasons, so we just did a hydrodissection on him 2.5 weeks ago. He came back this week, and he said the first night, he had the best night ever. He could sleep, he had any symptoms. Right away, these people, their symptoms improved significantly. It's pretty cool, very exciting. So there's some studies looking at hydrodissection of the cervical area, and I do this in my clinic very often. People that have any kind of cervical radiculopathy or any other injuries to the brachial plexus, we can hydrodissect that brachial plexus from any of the scar tissue and get some really nice release of those nerves and relief of symptoms. Very often I get patients that have the dorsal scapular pain, and they've tried everything, nothing seems to help. And there's a very nice nerve, the dorsoscapular nerve. It's part of the C5 nerve root and goes down right around that medial border of the scapula. And you can hydrodissect it, and these people are like, wow, it feels amazing. I had a woman, actually, she has a testimony on my website, that for 40 years she had that pain. It was like knife being stuck in that area. And every time she turned, she couldn't turn her neck. I did one treatment, and she was like 95% better. She comes back 2 weeks later. She couldn't believe it. She could turn her head, and that release of that nerve just completely relieved all her symptoms. So very exciting stuff. But there's so what I do is I combine the PRP and the hydrodissection together, and we seem to get really good results with that. But there's other supporting therapies that you need to add, or at least I add, to make it work very well. Like I said, I use laser too, so all my patients who get a PRP treatment afterwards go on a laser, and we know that the laser has some amazing things. Who was here last year? I gave a lecture on lasers last year. So a lot of great things that can happen as far as healing, but as far as nerves, we know that it decreases neurogenic inflammation, improves nerve cell metabolism, improves axonal sprouting, increases Schwann cell proliferation. Again, those wonderful Schwann cells. We're just trying to help them as much as we can. And it improves or decreases perineural scarring. The other thing, I have all my patients that are doing any neuropathy treatments or any regenerative medicine treatments. We do physical therapy or occupational therapy. So often these patients need to be doing some nerve gliding and some other nerve work to help those nerves maintain their released kind of behavior. And very often you have to have them do some exercise, some aerobic exercise, some strengthening exercise. And of course, diet. You guys seen my lectures possibly on diet. You have to eat the right foods. You have to absorb them. We try to get them to eat a little bit more fats. We know that fats tend to be supportive of nerve health, brain health. We know that the American Cardiology Association used to promote a fat-free diet, but last year or 2 years ago they said, oops, we were wrong. Actually, we need fat in our diet. So now they came out with a statement, no, the fat diet, wrong thing. We don't do that anymore. We know that the right amount of fat, the right fats, is definitely, okay, 3 minutes. Okay, very necessary. So again, we get our patients on a high fat diet, mostly from plants and some nuts and seeds. And we got to eliminate the toxins, right? A lot of our patients are walking bags of toxins, right? Unfortunately, it's the society we're in. A lot of them are taking medications that are toxic to the nerves. They're drinking alcohol and smoking. So when I treat my neuropathy patients, and I hope when you're treating your neuropathy patients, really got to help them get rid of these things. Right? So when you use this comprehensive approach, when you do the proper evaluation, when you use things like platelet rich plasma, lasers, therapy, nutrition, elimination, we see pretty good success. It's not perfect, but it's pretty good. But I think in the next couple of years, it's going to get even better, and it's going to be very exciting. So, in my clinic, we've treated radiculopathies, neuralgias, carpal tunnels, ulnar neuropathies, cluneal nerve neuralgias, which causes back pain, radiculopathies, peripheral neuropathies. All these things are improving with these regenerative treatments. But it does take a team approach, and you need a whole team to help you with this. And I hope that I am part of your team in the future when you're thinking of your neuropathy patients. And you're welcome to ask me any questions or send me an email. Like I mentioned earlier, I will be outside with an ultrasound, and I can scan your nerves, and I can show you how we look at nerves. So anybody who's interested, I'm more than happy to show you that. And like I said, you can come up and ask me any questions. Any quick questions right now? Go ahead, Walt.
I have a quick question for you.
Sure.
If you have a patient that you have on physical exam documented either hypoesthesia or hyperesthesia, and you believe they have some type of neuropathy, whether it be diabetic or something else, and you refer them for electronic testing, the EMG or other testing, and that comes back negative. But you also believe that you have to document the neuropathy for insurance reasons,
right.
Medicare, other things. Can ultrasound help diagnose abnormal nerves so you can have evidence-based medicine to show neuropathy besides a physical exam from a physician?
Right. So that's a very loaded question. So. Right, so very often Walt is asking, what about the patients that have the neuropathy symptoms and physical exam, and yet that electrodiagnostic study doesn't show any damage. Well, we know that EMGs and nerve conduction studies check for the large fibers, and patients that have early onset or sometimes just small fiber neuropathy, the EMG is going to be negative, the nerve conduction study is going to be negative. And we usually, a good electromyographer, I know I do this always, I tell my patients, even though this EMG is negative, it means that you don't have large fiber neuropathy, but you still have signs and symptoms of small fiber or other neuropathy. You can still just document your physical exam. The other part of the question was, will the ultrasound show any damage? I don't know at this point. I know that ultrasound can be pretty sensitive to see if there's any nerve swelling. So if it is going to be a large fiber neuropathy, it will. A small fiber neuropathy, it will not. So the ultrasound will not show small fiber. So with small fiber, you're left with a physical exam and a history, which honestly is the basis of our medicine. That always starts with physical and exam. But yeah, so just so you know, when you have patients coming back and you know you feel like they have neuropathy, but their electrodiagnostic study is negative, they can still have a small fiber neuropathy, which just doesn't show. And unfortunately, all these wonderful tests they're not 100%. They're not 100% sensitive. They're limited. And we know MRIs are limited too, right? So everything is, always goes down to a good physical and history.
Thank you very much.
Thank you. Any other quick questions? One last one back there. They are not covered by insurance at this point. These are self-pay at this point. And if you have questions about the pricing, you can ask me outside. Thank you very much.